would say the consortium actually was born very quickly and very organically. In March of 2020, myself and a group of neurointensivists were actually discussing amongst ourselves, trying to prepare ourselves in our ICUs to face this unknown tsunami of a pandemic. And we're all very concerned that these patients will have a neurological involvement, because in the past, in other pandemics, it's not rare that the nervous system would be involved. And we simply didn't know how it would be involved, what kind of pathologies we would see, to what extent. And we knew that we would be the people who would be on the front lines and be responsible for figuring out how best to treat these patients with so little information. So the GCS-NeuroCOVID Consortium, the idea was really conceived at that time, and we realized that even though we would be extremely overwhelmed as intensivists who serve on the front line, taking care of not only neurological patients, but all of the patients with COVID, it was absolutely important that we also capture data, so that when this hurricane has blown by, we could come back and look at what we've learned. And the other thing that we knew was how extremely overwhelmed the health systems would be, and how under-resourced we might be in conducting any research, because things were locking down. Our research teams, the folks who do 100% research, were not allowed to come into the hospital, let alone the ICU. And so we realized that the real-time data, the clinical data, would be collected by frontline workers who are already there, probably taking care of a lot of patients. And the other piece of that is we had no PPEs to spare. Nobody had enough at that time. We certainly couldn't use any more PPEs just to do research. So really the frontline staff, the doctors and the nurses and the clinicians on the front lines who are already wearing the PPEs would have to be the source of our data. And so we designed a study in a way that's extremely pragmatic. We really wanted to capture the most important data points without foregoing some of the things that we would have loved to know, but it would just take too much time and would make the whole study unfeasible. The other thing we thought about and we realized, being frontline workers, is at least at the very beginning of the pandemic, a lot of our regular processes, our diagnostics and regular clinical processes were very much interrupted because it's a new pandemic. We didn't know about how to deal with infection control, and so things that we were used to, we are very used to having as a routine matter, like getting a CAT scan on your patient, getting an MRI on your patient, doing all sorts of blood tests and maybe spinal taps on your patient. Became very difficult. So we realized that if we ask for that information, we may get very heterogeneous results from different, some centers might have it, some centers might not, some centers might be operating at a lower capacity, and we would introduce bias to our data. So we were careful to design a study that would avoid that kind of bias and focus on the data points that we can capture just by clinically observing the patient. And I initially thought that, just a small group of people would be able to pull this off or be willing to do this, because it's really adding to a lot of the burden that is already being felt by frontline clinicians working in this pandemic. To our delight and surprise, we had a huge amount of enthusiasm. The number of sites that registered was exponential. So from the day that we designed a study and open registration, which was the end of March in 2020, within, I think, 4 weeks, we reached over 100 sites. And then within 5 weeks of opening the initial study that we designed for the adult population, we've designed and started our pediatrics study as well, led by a group of excellent investigators who have a track record in studying critically ill kids and pediatrics kids. And so that was how the consortium began. And I was very honored to be able to present the first analysis of our adult population data at the EAN we have actually made a lot of progress beyond our imagination. So in this first analysis, we included 3 major patient cohorts, 2 from the GCS-NeuroCOVID and 1 from our close collaborator, the Energy Consortium, from the European Academy of Neurology. And we had over 3,000 patients in this analysis. And by being able to compare the different types of cohorts, we were able to draw some early conclusions. The biggest cohort in this study is what we call the all COVID cohort. And that is, the hospitals basically registered, included all of the patients who had COVID, not just those who had neurological symptoms, but everybody who was hospitalized for the defined period of time, which is 3 months, and systematically went through all of these patients and captured who had neurological symptoms, who had neurological signs, and documented and counted these events. And we put all of them together. And the reason this cohort is valuable is because it helped us look at the overall incidence of neurological events in a large population of patients who had COVID and were sick enough to be admitted to a hospital. And so we have 3 major findings. The first one is the neurological signs and symptoms were very common. We separated our neurological symptoms. We separate our neurological symptoms into things that a patient can report. So, patients can tell you whether they have a headache or they have abnormality in their smell or taste, and then versus things that a clinician at the bedside can determine even if the patient did not report this. So, for example, if the patient looks like they're having a stroke syndrome, they're having seizures, they're confused and encephalopathic. So things that we don't depend on patient self-report. And when we combine those events together, about 80% of the overall population of everybody who is hospitalized with COVID had one or the other, or if not both. If we limit ourselves to just things that we can determine, that a clinician can see without relying on patient self-report, then 50% of the population had some sort of neurological sign and syndrome. The reason it was important to separate these things is because in a patient who's really ill, they may not be able to report that they have a headache or they have abnormality in smell or taste if they're already on a ventilator, or if they had a stroke, or if they're very encephalopathic. So the self-reported symptoms are necessarily biased towards people who probably had milder disease, and that's why it was important to look at them separately. So our first conclusion was neurological events are actually quite common, and probably about 50% of the patients hospitalized experience some sort of neurological syndrome. We then asked, what's the most common syndrome? And I can tell you at the beginning of the pandemic, myself and probably many people included, what we most feared was probably some sort of terrible encephalitis where the virus just goes into the brain, attacks the brain. What we saw was actually that's one of the rarest forms of syndromes that we see. The most common by far, the clinical syndrome we saw was encephalopathy. And in this study, encephalopathy really is it encompassed everything. So anybody who is diagnosed as having delirium, anybody had altered mental status, anybody who were found to be in a confusional state, all of those things were captured in this terminology, encephalopathy. And that was about 50% of all of the hospitalized patients that we saw. The important question is the so what question. So what? So what if neurological symptoms are common? So what if encephalopathy is common? So what we did was we went in and we looked at predictors of death in this patient population, in hospital death. And we saw that having neurological syndrome, so having a neurological syndrome that can be determined by a clinician looking at the patient at the bedside, definitely increased the odds of death. And specifically, if that neurological syndrome is encephalopathy, your odds of dying is more than 5 times higher than somebody who don't have encephalopathy. If the neurological syndrome is coma, not surprisingly, your odds of dying is even higher. It's about 7 times. But in general, just lumping all syndromes and signs together, regardless of what it is, having some sort of neurological involvement increases the patient's risk of dying acutely during their hospitalization. And finally, we were able to run an analysis to try to look at what may be some of the predictors for people who are likely to develop a neurological syndrome. And what we saw was that the strongest predictor is actually people who have a history of neurological diseases. Again, in this pragmatic study, we didn't exactly ask all the sites to tell us what disease that is. And some patients may have multiple ones. They may have dementia and stroke, for example. But anyone who has a pre-existing neurological condition is at least twofold risk of developing a new neurological syndrome when they have COVID and are sick enough to be hospitalized.